So today we are going to move on with the pathology of the CNS. I know it's plenty and you keep learning new stuff and a little bit more of new stuff. So let's see and continue with that. So today we are going to speak about idiopathic intracranial hypertension and different causes of hydrocephalus, or some people say hydrocephalus. Whatever you use is correct. So some people read this as hydrocephalus and some people read it as hydrocephalus. It's up to you which one you say. Both of them are correct. So the idea here that there will be an increased amount of the CSF inside of the head. Remember what I told you before. I told you inside of the head there was this general rule. There is three things that exist inside of your cranium. One was the blood. The second thing was the CSF, and the last thing was the brain himself, the tissue, right? So if you have more CSF, that is going to compress the blood and the tissue, which can promote to something called herniation. Anytime the brain herniates, the patient is dead. You might ask me, what is herniation? Well, don't worry about it. We'll speak about it later. Herniation is when one structure is displaced into other area, which lead to it to become dysfunctional. Idiopathic intracranial hypertension, also known as pseudotumor cerebri. What is the idea of pseudotumor cerebri? Pseudotumor, false tumor of the brain. What does that mean? Well, in this patient, they have the exact same symptoms as a tumor inside of the brain, but they don't have a tumor inside of the brain. They don't have a mass. They just have an increase of intracranial pressure. So now you ask yourself, what are the symptoms of a tumor of a brain? Well, headache. You're like, oh yeah, so I have a tumor. I had headache this morning. It was bad. Yeah. Or, oh, I was working and at the end of the day I had headache and yeah. No, that's not the type of headache we are speaking about. The type of headache we speak about in case of tumor, it will be a debilitating headache that will wake you up from sleep. That's how bad it is. The headache will be so bad that it will wake you up from sleep in early morning, like 4 or 5 o'clock in the morning. You will wake up from the headache. It will be non-responsive to the NSAIDs. So wake you up early, non-responsive to the NSAIDs. That's tumor headache. So in pseudotumor cerebri, you will have the same, but when you do the CT scan, you will not be able to see the tumor. In addition to that, tumors do have compression, leading to focal neurological symptoms, which is something not seen in case of pseudotumor cerebri. So here they write increased intracranial pressure with no obvious finding on imaging. So risk factor include female sex, tetracycline, obesity, vitamin A excess, and danazol. I want you to combine these together. An obese lady that she's a teenager, late teenage, and she has a lot of acne because, teenage. So what is the treatment for acne? What do we give? Which antibiotic? We give vitamin A, that's correct. And the second thing we can give is an antibiotic, which is, you can give the following. You can give either clindamycin or doxycycline, okay? Doxycycline is a type of tetracycline. So, yeah, when you combine these together, you have more risk of it. So be careful about that obese teenager that has been taking both tetracycline for her acne or her vitamin A for her acne. It's associated with the dural venous sinus stenosis, which is how the CSF passes inside of your brain. Let's revise really quick the CSF flow. The CSF is produced by the choroid plexus, which is residing inside of the fourth and the third and which is residing inside of the lateral and the third ventricle. The choroid plexus is basically a developed blood vessels that work like a filter. So what is CSF? CSF is basically the ultrafiltrate of the blood. So the choroid plexus, it's just like a filter that be like, okay, don't pass me here any cells. Like, okay, no cells. So you want just the plasma? No. Take the proteins out. I don't want any proteins to go in. Okay, no proteins as well. What else do you want? Well, the minerals, I will not allow all of them. We'll just allow a few. So the CSF is basically the ultrafiltrate of the blood, okay? And this ultrafiltrate is created by the filter that exists inside of our ventricle that is known as the choroid plexus, okay? Okay, so after that, it's produced, it moves from the lateral to the third ventricle through the foramen of Monro. And then in the third ventricle, it moves to the fourth ventricle through the aqueductus of Salvius. And then in the fourth ventricle, it passes through the foramen of Magendie and the Luschka into the subdural sinuses. And then into the arachnoid granulation, it goes to the venous system. The finding goes as follow in idiopathic intracranial hypertension. It is headache, tinnitus, which is like zzz sound in your ear, and diplopia, which is double vision. Why? Because it can affect the cranial nerve number number 6, which is cranial nerve known as abducens. The abducens is responsible for the abduction. So we can say that it can lead to horizontal palsy, right? Horizontal movement of the eye defect. It cannot move it into the horizontal position, like laterally. No change in the mental status, however. Impaired optic nerve exoplasmic flow, which lead to a Babel edema. So let's try to understand this moment. What is Babel edema and what is happening exactly? Well, let's take a look at it. So in case of Babel edema, what is occurring exactly that the discs of the optic nerve is disappearing. Normally, optic nerve, you should be able to see the edges. But in case of Babel edema, you cannot distinguish the edges. Why is this happening? Well, basically what is occurring in this case, okay, one momento, that the CSF is compressing the backflow of the blood to the vessels, which is leading to the bulging up of the optic disc, leading to a Babel edema. That's why Babel edema occurs. So it's occurring because the CSF is getting compressed either due to an intracranial mass or increased amount of CSF himself. The next thing to speak about is as follows. Let's take a look. Visual field testing show an enlarged blind spot and peripheral constriction. Basically, guys, all of us have a blind spot, which is located exactly where the optic nerve exits. But when it becomes bigger, that's a sign of Babel edema. Lumbar puncture reveals increased intracranial pressure and provides temporary headache relief. Why? Because you are decreasing the CSF. However, in any patient that you get in the USMLE, that you are 100% sure that he has increase of the intracranial pressure, never do a lumbar puncture. Why? Because first of all, you must do a CT scan. Why? Because if the intracranial pressure was really high, and you used the lumbar puncture and you changed and altered the pressure from being really high to really low, really quick, what is going to happen to the brain? The thing that is going to happen to the brain is called herniation, which will lead to the death of the patient upon lumbar puncture. That's why always, if you suspect any type of increased intracranial hypertension, doesn't matter, tumor, pseudotumor cerebri, or anything, basically, aneurysm, do the CT scan before. After you do the CT scan, you can use acetazolamide and other diuretic to decrease the pressure a little bit, and after that you can do the LB, which is the lumbar puncture. You might advise the patient for weight loss in this disease, acetazolamide, which is carbonic anhydrase inhibitor that decreases the CSF production. Some people mistakenly think that acetazolamide is utilized because it has a diuretic function. This is incorrect. We use it because it's basically going to decrease the CSF production. Invasive procedure for refractory cases can be done, like CSF shunt placement and optic nerve sheath fenestration surgery for visual loss. So as you saw in the picture I just sent you, the optic nerve is messed up. He's getting compressed really bad. If he gets compressed for a long period of time, there is going to be reduced perfusion to the nerve and the retina, and the retina will basically die. For the sake of preventing that, you must relieve the pressure by making an incision in the optic nerve sheath, and thus that prevent massive compression of the nerve. Hydrocephalus is an increase in the CSF volume, which lead to ventricular dilatation, plus or minus increase in intracranial pressure. The idea of increased CSF, it can be to multiple causes. It can be three things mainly. It can be communicating, and the last one that we spoke about yesterday, ex vacuo ventriculomegaly. Let's start with ex vacuo ventriculomegaly. So the last one, basically. It appearance of increased CSF on imaging, like in picture C, you can see how large is the ventricle. Like, this is the right lateral ventricle. But actually, it's not. It's due to decrease in the brain tissue and neuronal atrophy. So it's not the CSF becoming more, it's the brain becoming less. Again, remember about the skull and the three things that contain brain tissue, blood, and CSF, right? So if you have less brain tissue, you will have more CSF. So yeah, in case of Alzheimer's disease, advanced HIV, frontotemporal dementia, Huntington disease, the brain mass is going to decrease. Decrease in the brain mass will allow the CSF to increase in the surrounding. For example, the caudate nucleus, when it disappears in case of Huntington, the lateral ventricle have more chance of becoming bigger. Intracranial pressure is normal in ex vacuo ventriculomegaly because it's not a true hydrocephalus. NBH triad is not seen. So what is NBH triad? NBH triad is normal pressure hydrocephalus triad that we'll speak about in a moment. So hydrocephalus, the communicating type, it goes as one of these. Communicating, that means that there is no obstruction in the tract. I mean, there is no obstruction in the lateral ventricle, third ventricle, fourth ventricle. No, it's not that. So communicating hydrocephalus is because of a decreased absorption from the arachnoid granulation. Why would that happen? So the arachnoid granulation, if you remember, arachnoid granulation, they were the structure that used to absorb the CSF after it has moved to the subdural space. See? So this is the sinuses, and this is the subarachnoid granulation that help to suck up the see the arachnoid granulation, these guys. So they help to suck the basically the CSF that has been dropped into the subdural space back into the circulation. What occurs, however, is something pretty interesting. For example, if the patient had previously meningitis, what will occur that this arachnoid granulation will be scarred, and the process of absorption will be disturbed, leading to hydrocephalus. So because you cannot absorb the CSF from the arachnoid granulation, for example, in scarring, post-meningitis, there will be an increase in intracranial pressure, which will promote to babble edema and herniation. The cause of death is herniation. The next cause is normal pressure hydrocephalus, pretty common, guys. It affects all people. Idiopathic, we don't know why it happens. The CSF pressure is elevated only episodically, which means the patient is normal, suddenly they have symptoms, and then they again normal. It does not result in an increased subarachnoid space volume, however. So when you do the CT scan, most likely, when you take a look at it, initially it will be normal, but eventually the ventriculi will be huge. But this is the joke. When you do a lumbar puncture and you check the pressure inside of the lumbar puncture, what will happen? Will you see high pressure or low pressure or normal pressure? Well, think about it. It's going to be normal pressure, exactly. So the pressure is increased, but it does not increase inside of the chamber. Immediately it expands the spaces. The expansion of the spaces basically lead to less pressure in the thingy. However, there is more volume of the CSF, so you must clear it out somehow. Expansion of the ventriculi distorts the fibers of something known as the corona radiata. What is corona radiata? Corona radiata is a white matter structure. So I'll show it to you. Corona radiata. In Latin, the word corona, it means like a crown, okay? Corona radiata is the crown. It's the white matter inside of our brain that connects the cortex. Just a moment, looking for a bit. Okay, this is fine. So you can see how the corona radiata goes, and it's going down through the cerebral peduncle, and basically it's a part of the corticospinal tract. See the green one. The green one is the corona radiata, okay? Okay, I found even a better image. Just a moment. This is corona radiata, guys. So it basically has all of the fibers of the corticospinal tract, corticobulbar tract, all of the motor fibers that are descending. This is corona radiata, okay? So that's corona radiata. The next thing goes as following. The compression of the corona radiata lead to the following triad. Wet, wobbly, and wacky. What does it mean? Wet means that the patient will have urinary incontinence. That is central. That means because of compression of the brain, the patient develops the urinary center in the brain, the patient develops the urinary incontinence. Gait apraxia, which is the wobbly, they have the magnetic gait. They feel such as their feet are stuck to the ground and they are trying to move, but their legs are stuck. Cognitive dysfunction is basically they become wacky. Wacky is cognitive dysfunction. They just have this form of dementia. The interesting things, all of these symptoms are because of compression. So if I clear up the CSF from there and decrease the pressure from decrease the CSF from all of this chamber, that will reduce the compression of the corona radiata. So do you think the symptoms will go away or will stay? They will go away, absolutely. So it's a reversible with CSF drainage via lumbar puncture or shunt placement. A lot of people ask me what is shunt. Well, look, guys, to be truthful with you, a neurosurgeon is an awesome type of a specialty, but they don't do much things. So what do I mean by that? So they can remove tumors, they come back. They can do multiple things, they come back. But there is one treatment that they can do, and it does not come back. That's cool. So what is it? It is, we call it ventriculoperitoneal shunt. Ventriculoperitoneal shunt. They place a shunt that goes all the way from the brain down to his abdomen. You are like, wow. So they pass it under the skin. It goes outside a little bit, but in general, it goes under the skin until it reaches the peritoneum. So it will constantly remove the extra CSF through a specialized valve and release it into the peritoneum? Yes. Well, but in the peritoneum, that will not lead to any problem? Not really, because in the peritoneum, there is constantly suckage of the extra fluid into the lymphatics and back to the venous system. So that will not be a problem. Wow, that sounds really cool, huh? So it can cure the patient, basically, and he will not have any symptoms after that. Pretty much, yes. Okay, so that's shunt placement. It's one of the successful neurosurgical treatment. Non-communicating or obstructive type of hydrocephalus. It's non-communicating hydrocephalus caused by a structural blockage of the CSF circulation within the ventricular system. So it's some form of a blockade. It can be, for example, a stenosis of the aqueduct of Salvius. In that case, what do you think will enlarge? If you block the aqueducts of Salvius, which ventriculi do you think will enlarge? The third one and the lateral one, right? Yeah. And the next thing they say, colloid cyst that is located at the foramen of Monro. Okay, if that happens, what will enlarge? No. The lateral. Remember. Lateral, lateral. Third. Aqueducts of Salvius. Fourth. Right? So if the blockage was here, only this lateral, well, for example, the left lateral will get affected. Okay. So, good. The next thing we speak about is multiple sclerosis, really famous disease these days. By the way, I'm utilizing 2022 version today of the first aid. If you would like, I can send it to you. Multiple sclerosis is an autoimmune inflammation and demyelination of the CNS. Ooh, so demyelination of the CSF. Who myelinate the CSF? Do you remember? Which cell can myelinate the CSF? Oligodendrocyte, absolutely. So the brain and the spinal cord are the CNS, with a subsequent axonal damage. It can present with optic neuritis, which is why optic neuritis? Because the optic nerve is considered a CNS portion, not a BNS portion. So the patient will have an acute, painful mononuclear visual loss due to the demyelination of his optic nerve. And it's associated with relative afferent pupillary defect, which means that if you put a light inside of the patient eye, the eye will be unresponsive sometimes. Speak more about that. Sorry, actually I made a little mistake there. So the afferent pupillary defect that occurs in multiple sclerosis is a little bit different. It's not about the light and the eye become unresponsive. That was syphilis, right? Remember, syphilis, if you put the light in eye of patient, what happens to it? Nothing. But in accommodation, the accommodation is normal. So what I'm trying to say here is the following. In syphilis, the light reflux is bad. But the accommodation is good. In MS, it is vice versa. So, brainstem and cerebellar syndrome, because of this affection, the patient might have diplopia, which is double vision, ataxia because of the cerebellar dysfunction, scanning speech. How does a scanning speech sounds like? Well, so I'm going to speak with you about multiple sclerosis. It sounds kind of robotic. The patient will sound robotic. Yes, no, exactly. The symptoms will be quite interesting. Yes. So you see, he becomes kind of robotic. And intention tremor, remember the zigzagging form of a tremor, right? So if you tell him to touch your finger, he will be like zigzagging until it touches it. Nystagmus of the eye. And INO. What is INO? It's intranuclear ophthalmoplegia, which is basically affecting the MLF, which is a white matter that connects the sixth cranial nerve to the third cranial nerve. I believe it will be discussed in ophthalmology just somewhere, isn't it? Oh yeah, it is. It is. It will be discussed in ophthalmology. Okay. So the next thing about MS, that pyramidal tract demyelination will lead to weakness and spasticity in the patient, pyramidal tract demyelination. Remember the pyramidal tract, what was the function of the pyramidal tract? Pyramidal tract, which tract are we speaking about? Pyramid. We are speaking about motor stuff, absolutely, which is the corticospinal and the corticobulbar tracts, basically. So the patient will have weakness and spasticity because it's an upper motor neuron lesion. Spinal cord syndrome, they will have an electrical shock-like sensation along the cervical spine and neck flexion. Pretty interesting. Neurogenic bladder can occur and paraparesis, sensory manifestation affecting the trunk and one or more extremity. All of the symptoms will be upper motor neuron symptoms. Why? Because the multiple sclerosis affect the CNS, not the BNS. The poor patient with MS can have affection of the olfactory and the optic nerve only, because they are considered a portion of the CNS, not the BNS. Symptoms exacerbate with increased body temperature, which happens during hot bath or exercise. In a hot bath, a multiple sclerosis patient will have the sensation of an electrical shock in his back. However, somebody who smokes a lot of weed and he's in withdrawal, weed like cannabis, and he's in withdrawal, he will have a severe abdominal pain with a hot shower. And a patient with polycythemia vera, on a hot shower, he will feel itchiness of his skin. Okay, relapsing and remitting is the most common clinical syndrome, clinical course, which means the symptoms will increase at some period of time. He will become really, really exacerbated, get hospitalized, upper motor neuron symptoms all over his body, and then the disease will disappear. It will last for a few years with no symptoms, and then it will happen again. Then a few years, no symptoms, then happen again. And it's chronic disease. It will never go away. So that's multiple sclerosis. It's more common in ladies. Why do you think so? Why do you think multiple sclerosis is more common in ladies? Because it's an autoimmune disease. So it's most often affects female in their 20s and 30s, more common individual who grew up farther from the equator and with low serum vitamin D. It has been associated that a loss of vitamin D or a decrease in the vitamin D is highly associated with this disease. So people who live in Europe, Northern Europe, like Norway and these countries, have higher risk. Why? Because they don't get exposed to a lot of sun. We don't understand the exact mechanism of that, but we know that there is a relationship. The findings include the following: an increase in the IgG level and myelin basic protein in the CSF. So what occurs in these patients is the following. They will have, if you check their CSF, true, they will have a lot of proteins in it. And also they will have bands. If you have an oligoclonal bands, which is a type of a protein, inside of the CSF, you are done. You have a diagnosis. However, taking CSF is not the least invasive procedure. So we prefer different things. For example, MRI. It's the gold standard. So what you will see in MRI, you will see a periventricular plaques, areas of oligodendrocyte loss, and reactive gliosis. It's periventricular. It reminds you of periventricular calcification that you saw in which disease? Which infectious disease led to periventricular calcification? There was one disease that we spoke about in microbiology that had periventricular calcification. And I told you to be able to differentiate it from other diseases. For example, we had toxoplasmosis and CMV. So the toxoplasmosis was intraparenchymal, which means it was all over the place. The periventricular one, however, it was CMV. Okay? So MS looks basically like CMV. The only trick to differentiate between it is in whom is the symptoms. CMV, you would think about a newborn or an HIV patient. Multiple sclerosis, it will be in a previously healthy young lady. So periventricular plaques, multiple white matter lesion disseminated in space and time. What does it mean disseminated in space and time? Disseminated in space, that means that the plaques can be a little bit in the brain, a little bit in the spinal cord, a little bit in the C3 of the spinal cord, C9, T12, sorry, there is no C9, C8, T12, a little bit in, it's always periventricular, but it can be sometimes more disseminated. However, that means dissemination in space, that it can affect many regions of the CNS not associated to each other. Disseminated in time means today I will have more affection of my left side. Tomorrow it will be my right side. The day after it, it will be in the area controlling my upper hand, the area controlling my lower leg, So basically that's dissemination in time. It means that the symptoms will be like going away and coming back. That's dissemination in time. Dissemination in place is which region is affected. That means treatment has two courses: treatment of the acute flares and the treatment of the chronic disease. They say stop the relapses and halt and slow down the progression of the disease by disease modifying therapy like beta interferon and galatiromir and natalizumab. So beta interferon is pretty interesting. However, there is one medication here, natalizumab. This drug is quite new. It was invented in a hospital called, damn it, just a moment, Tal HaShomer, the name of the hospital in Israel. And that medication, after it was invented, it was a breakthrough in medicine because they discovered that, wow, it actually worked quite well. A treatment of an acute flares with IV steroids can be done. And the IV steroids, when you give it to the patient, they are going to reduce the symptoms significantly. Okay, so that's nice. So why we just don't give the patient steroid forever after? Bad idea. They are good for the flares. If you keep giving them, you will have Cushing syndrome. Not good. However, symptomatic treatment for the neurogenic bladder can be done. Remember, neurogenic bladder, they cannot be. So you have to catheterize them, give a muscarinic antagonist to make them able to. So if they beat themselves so much, basically, you will give a muscarinic antagonist to make them stop the incontinence. And botulinum toxin injection sometimes if they have constant contraction, which can occur in neurogenic bladder. Well, in the case of neurogenic bladder, you have destruction of the upper motor neuron, correct? So this is the upper motor neuron, and this is the lower motor neuron going to the bladder. So this is the bladder. It's a CNS disease, so this is destroyed. So the bladder will be, so the lower motor neuron, remember what I told you about the lower motor neuron? Was it mostly activatory or inhibitory, the lower motor neuron? The lower motor neuron was activatory in general, while the upper motor neuron was inhibitory in general. So if you destroy the inhibitory function, the symptoms will be most likely to be activatory. So constantly the bladder will be contracting, forcing the patient to be himself. So you must give stuff that relax the bladder down, like muscarinic antagonist and botulinum toxin injection to reduce the spasticity of the bladder. Speaking of spasticity, because of the destruction of the corticospinal tract, the patient will have a spasticity all over his body. Upper motor neurons are inhibitory, lower motor neurons are stimulatory. Basically, lower motor neuron, they always want to activate all of the muscles in your body. But the upper motor neuron, they are more wiser. They tell them, no, you don't work, you work, okay? So, spasticity occurs because of the absence of the upper motor neuron function. And to decrease the spasticity, you can use baclofen, which is a GABA-B receptor agonist that relax down the muscles. Pain can occur and it can be relieved by TCAs, which is tricyclic antidepressant and anticonvulsant. They mention in the picture here that neurological symptoms include fatigue, depression, ataxia, and intentional tremor. Depression in these patients is no joke because they do kill themselves a lot. And you need to be really careful with the psychological treatment of these patients and make sure they have a therapist. Speech, the patient will have this dysarthria. It's a mechanical problem of speech, and the scanning speech because of the cerebellar dysfunction. The ophthalmic problem, it will be optic neuritis because of cranial nerve number 1 affection. Diplopia can occur because of the abducens dysfunction. Because the diplopia occurs because of affection of some areas in the pre-central gyrus. Yes. So the pre-central gyrus and the frontal lobe, they control the movement of your eyes. So if these movements are not synchronized, you will have a problem. In addition, there is something called intranuclear ophthalmoplegia, which occurred due to affection of the medial longitudinal fasciculus, which is a communication between cranial nerve number 3 and cranial nerve number 6. Absence of this connection will lead to a dysynchronized movement of your right and left eye, which lead basically to something like this. Spinal cord affection can lead to sensory symptoms, weakness, and spasticity that can be decreased by baclofen. Baclofen is for your back, so it relaxes the spasticity. Baclofen. Okay, guys, 10 minutes break. See you in 10 minutes. Okay, guys, so let's continue. Now we are going to continue with the demyelinating syndromes. So the first demyelinating syndrome is an osmotic demyelinating syndrome, and it goes something like this. Osmotic demyelination happens mostly secondary to a rapid correction of sodium disbalance. What does that even mean? Well, sodium disbalance can occur, for example, from somebody who drinks so much water. Or do you remember any endocrinological dysfunction that can lead to the sodium becoming really low? Which sodium disorder make the sodium to become really low? I hope you are thinking about inappropriate secretion of antidiuretic hormone. Okay, so that guy can lead to it. Okay, so let's see what they write here. Osmotic demyelination syndrome, also known as central pontine myelinolysis, which is destruction of the myelin sheath in the bones. So, this is interesting. Can somebody tell me what myelinate the bones? Which cell is responsible for the myelination process of the bones? Well, it's basically the oligodendrocyte. Okay, so massive axonal demyelination in the pontine white matter secondary to a rapid osmotic change. Most commonly, iatrogenic, meaning it happens in the hospital. So it's an iatrogenic correction of hyponatremia, but also a rapid shift of other osmoles such as glucose. For example, somebody who has a really high glucose and you decrease it really, really quick. Okay, the patient can have acute paralysis, dysphagia, diplopia, and loss of consciousness. Let's try to understand why. The paralysis is because of the affection of the corticospinal tract, dysarthria, dysphagia, and diplopia. This is because of cranial nerve nuclei dysfunction, especially nucleus ambiguus, which is normally present inside of the bones. Dysfunction of this motor nucleus will lead to symptoms that we consider to be bulbar symptoms. Bulbar symptoms is dysphonia, dysarthria, dysphagia. Correction of the serum too fast. So what happens? They say from low to high, your bones will die. What does it mean? So if we consider this is your bones or the vessel, the cell of your bones, and this is the sodium here. So from low to high, if you increase the sodium here, is the shift is going to be from in to out or out to in? I hope you are thinking that it will be from in to out, right? So from in to out really quick, what happens? The cell is going to shrink down. That's osmotic demyelination syndrome. From high to low, your brain will blow. So again, if you decrease your sodium really, really, really quick, the shift of the water is going to be from the outside to the inside. That is going to make your brain cell becomes much bigger. That leads to cerebral edema and herniation. Acute inflammatory demyelinating polyneuropathy. Wow, that's a long name. It's also known as Guillain-Barré syndrome. It's an autoimmune condition in which we have destruction of the Schwann cells. So basically, remember the how we said in MS, multiple sclerosis, we only had affection of the CNS. In acute inflammatory demyelinating polyneuropathy, also known as Guillain-Barré syndrome, the problem is going to be solely and solitary in the BNS. So it's due to a destruction of the Schwann cells via inflammation and demyelination of the motor fibers, sensory fibers, and peripheral nerves. It affects all of the cranial nerve except the cranial nerve number 1 and number 2 because they are considered a CNS part. It's likely facilitated by molecular mimicry and triggered by inoculation or stress. What does that even mean? Some people are normal, nothing is wrong with them, but they get exposed to some inflammatory condition. So their bodies start making, immune cells and antibody against it. These immune cells and antibody are going to basically do what? They are going to attack the Schwann cells because of molecular mimicry, meaning they will be looking like it. Okay, that's why they get attacked, the Schwann cells. So it results, despite association with infection, like Campylobacter jejuni and viruses like Zika virus, in addition to orthomyxovirus, the causative agent of influenza, no definitive causal link to any pathogen exactly, but in the USMLE, they love to make this equation with Campylobacter jejuni and Zika virus. The patient will have an ascending muscle weakness and paralysis. Do you remember which type of disease? We had a descending muscle weakness and paralysis. This is ascending. There was something descending. I hope you remember about Clostridium botulinism. That was descending. Also, the patient will have an absent deep tendon reflexes because of the lower motor neuron symptoms, beginning in the lower extremity. Facial paralysis can occur, it will be a bit late, and respiratory failure is the cause of death and is common. So remember, actually, all patients with Guillain-Barré syndrome, when it progresses, must be started on ventilation. However, keep in mind that this patient must do one thing. You must be careful about one thing of this patient. I mean, Guillain-Barré syndrome patient. Be careful that their respiration stay normal. Otherwise, they will die. So you may see autonomic dysregulation like cardiac irregularities and hypertension or hypotension, depending. Even sensory abnormalities because it attacks all nerve. The patient survive with good functional recovery. However, just you must be careful that they pass the respiratory arrest phase. Okay? The next thing goes something like this. Let me just check some. Oh, you are writing the answers, but I could not see them. Okay. So, it was like, why they are not answering? But now it makes sense. Okay, good. So, results in symmetrical ascending muscle weakness and paralysis. Okay, spoke about this point. Just want you to know that the only thing to be careful about in Guillain-Barré syndrome is what? What kills them? The respiratory arrest. Yes. Okay, good. So this patient, it's associated with antibody, the disease. We just spoke about that. So they will have inside of the CSF, what will happen to the protein amount in the CSF? This will be high because of the immunoglobulin, basically. So increased CSF proteins, but normal cell count, which is highly atypical. And somebody is asking what is, I really did not notice this question, sorry guys. So somebody is asked what is dysarthria. It's a problem in the speech, but it's a problem in the articulation of the speech. What do I mean by that? It's basically not a problem in the center of a speech. It's not a Broca aphasia or Wernicke aphasia. It is a problem in articulation of the speech. It's a motor disorder, okay? So they cannot execute the speech because their tongue is paralyzed, okay? Or their throat cannot blow off the air. So this patient with Guillain-Barré will have albuminocytological dissociation, meaning that their albumin will be high, but the cells will be low in the CSF. It's highly specific for Guillain-Barré. Respiratory support is crucial until recovery. However, if the patient have it, don't worry so much. Most likely they will recover if they don't die from the respiratory arrest. Disease-modifying treatment like a plasma exchange or IV immunoglobulin will help. No role of steroids, which is kind of weird since it is mediated by immune system. However, the steroid don't help. So, plasma exchange and the USMLE also can use the word plasma ultrafiltration. It's the same thing. Basically, you are trying to clear out the antibody, or by giving IV immunoglobulin, you make your body produce less immunoglobulin, which tricks your body to produce less immunoglobulin, which means less symptoms. Acute disseminated encephalomyelitis, also known as post-infectious encephalomyelitis. I'm sorry to say that, but it has been noticed in COVID vaccination. It's a multifocal inflammation and demyelination after infection or vaccination. Influenza vaccine is associated with it. Also, some cases of MMR vaccine. If somebody comes and tell you about this, tell him yes, it's true, but the prevalence of this is 1 per 100,000. basically, if you come to me, I will still take the vaccination because the chance of getting a life-threatening disease is much more higher. The chance of getting this in a population is pretty low. So if you say a country with a population of 1 million people, only 10 people will get it if you vaccinate all of them. However, if we speak about the MMR vaccine, like for example, the MMR vaccine, if measles affect a population of 1 million, it will, and they are not vaccinated, it can kill 3 out of 10. That's a 300,000 people. So yeah, take the MMR vaccine. Somebody is asking, can Guillain-Barré occur after COVID vaccination? Absolutely yes. It has been documented. It does. So it's basically a stressful factor that activates the inflammatory cascade. It presents with rapidly progressive, multifocal, multiple lesions, neurological symptoms, and altered mental status. Charcot-Marie-Tooth disease, just they ask about one picture and the diagnosis. I will read the whole thing, but I will show you the picture and I will tell you the diagnosis. Also known as hereditary motor and sensory neuropathy, also a demyelination disorder that is hereditary, group of a progressive hereditary nerve disorder related to a defect in the production of a protein involved in the structure and function of the peripheral nerve and their myelin sheath. Autosomal dominant, that means if the father is affected, what is the chance of the baby getting it if the father is affected? 50%, that's correct. And it's associated with foot abnormalities. This is exactly what they show you. They show you the bis cavis, the hammer toe. They show you the leg. They show you a photo of the leg. Basically, when you see that photo, they are asking you about this. It will not be in any other thing. Bis cavis. Okay, so this is the thingy and this is the hammer toe. Okay, just imagine that there is a cave in his leg. Okay, lower extremity weakness, which is a foot drop and sensory deficit. Most common cause is CMT1A is caused by something called the BAMP22 gene duplication. Sadly, the only thing that you have to know, well, not sadly, actually, luckily, the only thing that you have to know is the bis cavis and the name of the disease. That's what they will ask you about. They might increase it to you and ask you which type of disease is it. It's a demyelinating disorder. The next disease we spoke about it before. It's called progressive multifocal leukoencephalopathy, which is secondary to a GC virus. Guys, what is the chance that we have GC virus? Is it common or uncommon, the GC virus? The chance of me having GC virus, somebody said low, somebody said common. The chance that me or you have GC virus is around 90%. But it's asymptomatic. All of us have GC virus, but basically it's just sleeping. How to wake him up? Water? No. Yes, HIV. Low CD count. So demyelination of the CNS is due to destruction of the oligodendrocyte. If you are asking which count, yes, it's 50. Oligodendrocyte, which lead to reactivation of the GC virus. It's associated with an immunosuppressive treatment, such as in cases of lymphoma, leukemia, AIDS, or organ transplantation. So anything that leads to immune system dysfunction can promote to it. It's rapidly progressive from the name, which means that it becomes worse really, really quick, usually fatal. Predominantly involve the parietal and the occipital lobe. That is why they have visual symptoms. They can see stuff. Increased risk associated with natalizumab. So, what is this natalizumab? It's a medication. For which disease? Which disease? Autocorrect is ruining somebody's day. Yes, it's MS. Okay, so other disorders are Krabbe disease, which we'll speak about in Krabbe disease, which we'll speak about in cases of lysosomal storage disease. The same with metachromatic dystrophy. These two are considered lysosomal storage disease. We will speak about them in the chapter of metabolism. And finally, we have adrenal leukodystrophy. Adrenal leukodystrophy is a form of a paroxysmal storage disease, if you remember, paroxysmal disease, and which we have dysfunction of the adrenals and we have absence of the white matter, right? Thus, leukodystrophy. The next disease is known as neurocutaneous disorder. When we speak about these, first of all, they have a lot of memorization. But before memorization, I would like to understand something. What I would like to understand is why the hell there is neurological stuff and cutaneous stuff. Somebody just wrote ectoderm. He's right, but what he means? Basically, you remember we have the ectoderm, the mesoderm, and the endoderm. From the ectoderm, we have two structures coming out. Does anybody remember what are the two structures? The skin and the neuronal plate, which is basically giving the CNS. You are right. That's why people with CNS and nerve stuff is going to also have skin symptoms. This first disease is Sturge-Weber syndrome. Okay, guys, I know this is kind of annoying, so let me start speaking about the Soviet Union. Soviet Union last president, Gorbachev, if you know that guy, he had something on his head, something like this. It looks like somebody ported some wine on his head, right? That's why we call it the port wine stain, okay? So this is the last president of the USSR. Okay, so you can see this is the port wine stain. So the port wine stain is highly associated with Sturge-Weber syndrome. It's a congenital, non-hereditary, meaning that if you have it, you will not give it to your child. Anomalies of neuronal cross derivatives. Somatic mosaicism, which means that the patient will have the symptoms, but he cannot transmit it to his son. Of an activating mutation in one copy of the GNAG gene. So the patient can have multiple symptoms that will be only in him. Capillary vascular malformation will lead to the port wine stain, which is, yeah, it can be as bad as this, or it can be like Gorbachev, quite mild. So, also known as nevus flammus or a non-neoplastic birthmark, yes, and basically, when you take a look at the port wine stain, it's various. It can be mild, like in case of Gorbachev, or it can be really bad, like this. Okay, it's permanent, but you can give some treatment for it, basically with the liquid nitrogen, for example. So, in the cranial nerve V1 and V2 distribution, which is the ophthalmic and the maxillaris. Ipsilateral leptomeningeal angiomas with calcification can occur. So the patient can have, wait a second, leptomeningeal angiomas. Is that a tumor inside of the brain? Yes. I want you to see this tram appearance. It means like it's a clear cut. You see? This is characteristic of this calcification. This calcification of the leptomeninges will have a clear cuts. Okay? This is why the patient develops seizures and epilepsy. They can have intellectual disability as well. However, there is one more thing. Okay, so as you notice, there is a lot of vascular stuff happening. I mean, the port wine stain on the face, that was vascular. Also, they developed the angiomas in their head, that was vascular. And now they are stupid. Oh my God, are you speaking that the last Soviet leader was stupid? All of them were. Okay, and episcleral hemiangioma, which is basically blood vessels that appears on the sclera, as you can see here. Okay? So this is hemiangiomas. Okay, episcleral hemiangioma, which lead to an increased intraorbital pressure, which lead to an early onset glaucoma. So what is a glaucoma? It's an increase of the intraocular pressure that promotes to the destruction of the optic disc and blindness. also called encephalotrigeminal angiomatosis, which means that there will be multiple angiomas in the brain and in the trigeminal nerve distribution, which is actually true. So that's Sturge-Weber. Tuberosclerosis. Oh yeah, they like this one. Autosomal dominant, so it's with variable expression, meaning variable expression. Ooh, what does that mean? That means that people with the same genotype can have various severity of the phenotype. Variable expression. A mutation in the tumor suppressor gene, so it will be an deactivating mutation, TSC1 on chromosome 9, and also which encodes for hamartin, and also on chromosome 16, which encode for tuberin, the TSC2. Hamartomas can occur in the CNS and the skin. Remember, hamartomas are benign tumors that located at the exact same place where the tissue originated from. Meaning, if you biopsy this tumor, they will have normal architecture. But there is hyperproliferation of the cells. They also have angiofibromas, which can be seen here. They call it aciniform lesion, which means they look like acne. The angiofibroma like to affect two areas. The scrotum, they like to show you a picture of the scrotum, as you can see here. And the face, the aciniform lesion, which is something like this. Okay. This patient with tuberous sclerosis, they can develop mitral regurgitation. Remember, it was sounding like a systolic murmur, right? It was a holosystolic murmur, exactly. The ash leaf spots, which looks something like this. Ash leaf spots are white. Cafe au lait spots is brown. So that's important to differentiate. Cardiac rhabdomyoma, which is a tumor most commonly, what do you think? Is rhabdomyomas more common in the ventricles or in the atrium? Ventricles, yes, ventricles. Myxoma was more common in the atrium. Intellectual disability, again stupid, and renal angiomyolipoma. This tumor is pretty characteristic, guys. It's some of these things that you will never see in any other disease. So you can see, they will tell you a renal biopsy with this. This is a blood vessel here, okay? This is fat cells. They don't show the myo here, but they also contain muscle, okay? So it's a tumor of the kidney that can have vessels, angiomyolipoma, vessels, muscle, and fat. Well, yeah, this kidney. You can see, looks like somebody was eating on it. I just wanna, oh, nice. Okay. You can see the fat, the brown stuff, and you can see the muscle. Okay. Also, they can have seizures, and because of the hamartomas in the CNS, and finally the Sjagren patches. The only thing to know about Sjagren patches that they are above the skin, meaning that they are over the skin. What the hell is that? No, wait, I'm not speaking about this. This, yes. So you can see if you move your hand on them, you can actually feel them over the skin. They are elevated from the skin. Okay, more incidence of subepidendymal giant cells, astrocytomas, and inguinal fibroma in the fingers. So the inguinal fibromas is no problem. You just need to know a picture of how it like rising from the nail. This is inguinal fibroma. But the other one I'm more interested about, which is the subepidendymal astrocytoma. Basically, subepidendymal. Well, basically, the epidendymal cells are cells that are located inside of our, like, they are covering our ventriculi in our head. So these guys as you can see, will form these basically tumors inside of the ventricles, as you can see in all pictures. Okay? Inside of the ventricles. Good. The next thing is neurofibromas. We have type 1, type 2. Type 1, autosomal dominant, 100% penetrance, meaning if you have the genotype, you will have the phenotype. A mutation in the NF1 tumor suppressor gene, so it's a deactivating mutation on chromosome 17 and encodes for neurofibromin, which is a negative RAS regulator. So since it's a deactivating mutation, so the neurofibromin will not be there. So the neurofibromin is a negative RAS regulator. So the negative RAS regulator will be gone. That means the RAS will be hyperactive, leading to more proliferation of the cells. So cafe au lait spots will be seen, which looks like, yeah, somebody dropped a coffee in your body. The next thing that you can see in these patients that they will have, again, intellectual disability, cutaneous neurofibromas, again, skin stuff. And guys, the older this patient will get, the worse the symptoms will become. Lesh nodules, which is pigmented iris hamartomas, as you can see here, it's the brownish stuff. Do not confuse it with the battlefield brush. One second. Battle brush lesion, which are seen in Down syndrome. Also, we have optic gliomas can be seen in this disease, which is a tumor of the optic nerve. Okay, optic glioma. It's a tumor of the optic nerve that can compress the retina and increase the intraocular pressure. As you can see in this picture, this is the optic nerve, this is the optic nerve, and this is the mass. It can push forward the eye, leading to something like this. Okay? Sadly, in such patient, you must remove the whole eye with the whole nerve, because anyway, the eye is dysfunctional. Okay, so the next thing we see here is that they can develop pheochromocytoma, which is a tumor that secretes plenty of catecholamines. They also can have seizures and focal neurological signs because of the meningiomas and the compression of the tumors, in addition to the bone lesion, which is basically the sphenoid bone dysplasia. So they also call it Recklinghausen disease. Okay, so von Recklinghausen is 70 letters. That's why it is chromosome number 17. Also, Nero 5, and ptosis. This is also 17 letter. Neurofibromatosis is 70 letter, thus chromosome 17. However, neurofibromatosis type 2 is chromosome 22, mutation in the NF2, and yeah, it will encode for Merlin. They used to say back in time that neurofibromatosis is type 1. It is a diagnosis of skin lesion and tumors. Neurofibromatosis type 2, it's only tumors. So the patient will have a bilateral vestibular schwannoma, which is a which cranial nerve? Which cranial nerve is vestibular schwannoma? Which cranial nerve number? Which number is it? Vestibulocochlear nerve, if you remember. Number 8, absolutely. So they like to call it as well acoustic schwannoma or vestibular schwannoma. So this patient will also have juvenile cataract, meningioma, and epididymioma. This is irrelevant. I just want you to see the schwannoma. So bilateral schwannomas, as you can see them, they are originating from the bones where the nerve normally originate from. Here you go. Okay. The next thing to appreciate is von Hippel-Lindau, VHL, so chromosome number 3, VHL. So autosomal dominant deletion of the VHL gene on the chromosome number 3P. So P, VHL, ubiquinated hypoxia inducible factor 1A. Okay, so what's up with this patient? Okay, so this hypoxia inducible factor type 1A is basically going to lead to, well, when it's mutated, it's going to lead to the body thinking that he is in a state of hypoxia. When your body thinks that he's in a state of hypoxia, he will start proliferating more blood vessels, leading to hemangioblastoma, which is a high vascularity with a hyperchromatic nuclei when you take a look at this tumor. So they have many blood vessels in them and many basically hyperchromatin, which means like a lot of nuclei. All cancers have that actually, it's not specific. So the increase of the nuclear material because it has to proliferate more often. In the retina and the brainstem and the cerebellum and even in the spine, they can occur. See? However, make a note please. Hemangioblastoma do produce EPO, erythropoietin. So you might find in the same patient erythrocytosis. Angiomatosis can occur in these patients and a bilateral renal cell carcinoma and pheochromocytoma. Do not forget about the polycythemia that can occur secondary to cerebellar hemangioblastoma that produce EPO, erythropoietin. Numerous tumors, both benign and malignant, can be seen. So they have this mnemonic, which is hemangioblastoma, angioma, renal cell carcinoma, and pheochromocytoma. All of these are the tumors that occur in this case. As you can see, for each disease, you must know the constellation, and you just need to know a few things here and there. The next thing is cancer in the people of the CNS cancers. CNS cancers are quite a list. So let's start with it. We have glioblastoma. Also, this is, maybe you heard the story. So, person X had a brain cancer, died in 6 months or died in a year. Yep, this is the worst case scenario. It's a glioblastoma. It's a grade 4 astrocytoma. Grade 4 means too late. Cancer are subdivided to 1, 2, 3, and 4. Of course, there is multiple ways to grade them, but to make it simple for you guys, if it is 1 or 2, it's treatable. If 3, it's highly unlikely to be treatable. 4, it's not treatable. Okay, commonly, a highly malignant primary brain tumor with 1 year median survival. It's found in the cerebral hemisphere. It can cross the corpus callosum. That's why we call it the butterfly glioma, because it can go across the corpus callosum, which is the structure connecting your hemispheres. That's a really, really bad type of tumor. So it's associated with an amplification of the growth factor, basically, which is EGFR. So which is the epidermal growth factor receptor. Okay? So epidermal growth factor receptor mutation will lead to hyperproliferation of these cells. Astrocyte origin, GFAP positive, when you basically check the tumor, they have this pseudopallisating pleomorphic tumor cells. What does that even mean? If you have a fence to your house, you know what does a fence look like something like this, right? This is the fence, if it is made out of wood. So this is fence, it's up and down a little bit, plus or minus. So in histology, when you take a look at this, you can see this structure that is going up and down, basically. So the next thing, this is pseudopallisading, we call it, which means this fence-like structure. Pleomorphic tumor cells border central areas of necrosis. So in the middle of this pseudopallisading area, you will have necrosis. Hemorrhage and microvascular proliferation might occur as well. If you take a look at this, again, this is pseudopallisading, the fence-like structure, and in the middle, it is necrosis, okay? Okay, guys, let's have our 10 minutes break, and I will see you in 10 minutes. Okay, so in ladies more than men, because it's stimulated by estrogen, and it occurs along the surface of the brain or the spinal cord. So think about it logically. It will be to the outside, right? It will be to the outside of the brain. As you can see here, this is the brain, and it's to the outside of the brain. They put an arrow here, which is the tail of the tumor. Any meningiomas, doesn't matter, it's in the spinal cord or in the brain, it will have a tail, okay? So actually, personally, that's how I used to identify it. I just look for the tail. Meningioma. Okay, so let's start looking for tails. So this is a meningioma. I hope you can see the white tail, the white tail. Good. Next one. Okay, there is a little white tail, a little white tail. Next. You are like, oh, now this is not a meningioma. No, it is, guys. It's in the medial surface of the brain, and you can see the tail here. Okay, so this is still a meningioma. Okay, so let's see what they say about it. Extraaxial, external to the brain parenchyma, and it may have a dural attachment, which is the tail basically. Often asymptomatic, but present with seizure and focal neurological signs, which is caused by the compression. So all of the signs is because of compression. It has a good prognosis, and the resection is possible, and you even can do radiosurgery in it. I hope you know what is a gamma knife. A gamma knife, it's a form of radiotherapy in which you can destroy the tumor without opening the brain. The idea in gamma knife that you have frequencies of light beam that can go through the skull and be concentrated from multiple areas and can burn the tumor without opening the head. That's radio surgery. Arachnoid cells origin, spindle cells concentrically arranged in a whorl pattern. What does that even mean? So if you take a look like this, it looks like this thing that forms in the water. I don't know how do we call it, but it looks like this, you know? This one? Yep, so this is the whorl pattern, okay? So, the swirling thing, the swirl, exactly, like it has this is the whorl appearance. It looks like a swirl. Yep, as you can see in this picture. They even can develop a pneumoma body, which is a type of dystrophic calcification, okay? Pneumoma body, which is laminated calcification, make a note, dystrophic calcification. The next thing is hemiangioblastoma, which is most commonly in the cerebellum. We spoke about it when we spoke about VHL, which was von Hippel-Lindau. It was the H in the Harbin mnemonic. Remember the Harbin mnemonic, hemangioblastoma, A for angiomatosis, the R for renal cell carcinoma, the B for pheochromocytoma. It does produce EBO, absolutely correct. It's found with the retinal angiomas. It can produce erythropoietin, which lead to secondary polycythemia. A blood vessel origin, closely arranged, thin-walled capillaries with minimal intervening parenchyma. So basically, in this tumor, in histology, we'll just see a bunch of vessels. So this is a blood vessel, and you can see the RBCs in it. Blood vessel, blood vessel, blood vessel, many blood vessels next to each other with RBCs inside of them. The next tumor is pituitary adenoma. It's so many types. It might be non-functioning or silent or hyperfunctioning, which produces hormones, which are normally produced from the pituitary gland. Non-functional tumor presents with a mass effect. Well, it's a big tumor, so it can compress the chiasma optica, which lies directly under the pituitary gland. So that can lead to bitemporal hemanopsia due to the pressure on the optic chiasm. So what is bitemporal hemanopsia? The patient will not be able to see the lateral portion of his visual field. Pituitary apoplexy can lead to hypopituitarism, which means when the pituitary is super big, the blood supply to it will not be as much. So it can just necrose and die. And the patient will have a massive hypopituitarism. Prolactinoma classically presents with galactorrhea, which is the breast start making secretions because of the prolactin. And amenorrhea. Why? Because the prolactin can inhibit GnRH. The inhibition of the gonadotropin releasing hormone will decrease the FSH and the LH. The decrease of the FSH and the LH will decrease the estrogen and the progesterone. Okay. decreased bone density due to suppression of estrogen in female, and decreased libido because of the decreased testosterone in both females and males. Infertility in males as well. Remember, prolactin inhibits the GnRH. So infertility, decreased libido, and decreased estrogen makes sense. Treatment with the dopamine agonist because they decrease the prolactin release. So bromocriptine or cabergoline, both of these are dopamine agonists. In the near future, I will be telling you, be careful when you give these drugs because dopamine, they have a side effects which is gambling. People who utilizes dopamine have more tendency to start gambling, so it's serious. Since the tumor is in the pituitary, and instead of opening the head, you can do a transsphenoidal resection from the nose. Hyperplasia of one type of endocrine cells found in the pituitary, most commonly from the lactotrophs, which produce a prolactin. So in that case, we'll have hyperprolactinemia, but if it was from the somatotroph, we'll have acromegaly or gigantism in boys, in children, acromegaly in adults. Corticotrophs will have Cushing disease because it's from the brain. We call it disease, not syndrome. And rarely thyrotrophs, which will cause us cause us hyperthyroidism. Gonadotroph, that will lead to increased FSH and LH. The next thing is about schwannomas. Schwannomas. In which disease did we speak about schwannomas? Come on. Where did we speak about schwannoma? Neurofibromatosis type 2. So basically this patient can have this cerebellopontine angle tumor, which is the area between the cerebrum and the bones. No, not this one. Yeah, this one. This is schwannoma. It benign, involving cranial nerve number 5, 7, and 8. All of them have one thing in common. All of them originate from the bones, but can go along any peripheral nerves, often localized at cranial nerve number 8 in the internal acoustic meatus. Vestibular schwannoma can present with hearing loss and tinnitus, which is zzz sound, and bilateral vertebral vestibular schwannomas found in neurofibromatosis. Neurofibromatosis type 2, you will have 2 schwannomas. Resection and stereotactic radiosurgery, which is the beam light therapy. Schwann cells come from neuronal cluster region. That's why they are S100 positive. Biphasic, dense hypercellular areas containing spindle cells. And you have myxoid area. Let's take a look at it. So you can see all of these myxoid areas in between. And this is the spindle cells. You don't know what is the spindle. It's a structure that looks like this that we utilize in sewing. Okay? That's look like a spindle. That's a spindle cells. So let me just show you a spindle. Yes. Okay, this guy. This is a spindle. So when I say spindle cell, look, it looks kind of like it. Okay, good. So let me take a look. How much do we have left? Okay, this. Oops. Okay, and this. Okay, so let's just try to finish the childhood tumors. The childhood primary brain tumors. We have pielocystic astrocytoma, which is a low-grade astrocytoma. It's basically like, some tumors are more common in children, subtumors are more common in adult. Just a quick review. If you take a look, this is the brain. There is this brain called the tinctorium. Most adults' tumor are over the tinctorium. Most childhood tumor are under the tinctorium. This is the general theme. So it says something like this. Low-grade astrocytoma, most common primary brain tumor in childhood, usually well circumscribed in children. Most often found in the posterior fossa at the cerebellum under the tinctorium, but rarely can be supratinctorial. Okay? But in general, all of these tumors must be subtinctorial, except, basically. It's rare to be not under the tinctorium. It has good prognosis. Bilocystic astrocytoma. The name is really useful. You will see why in a second. Astrocytoregion, so astrocytoma. GFAP positive, like a glioblastoma, but a glioblastoma was malignant, right? Bipolar neoplastic cells with a hair-like projection. It's associated with the macrocytes and something known as the Rothel fibers, which is a eosinophilic corkscrew fibers that you can see here. Oh yeah, this guy. And really important, this thing. This is what they show you in the exam. I hope you can see the solid portion and the fluid portion. So there is solid and there is a fluid in the same tumor. Bilocystic. So I just imagine the bilo, it's to be like the solid stuff, and the cystic to be the cyst here that is full with the fluid. So that's bilocystic astrocytoma. So it has both cystic and solid component. Medulloblastoma is something really horrible to hear about. The most common malignant brain tumor in childhood. Commonly involve the cerebellum and can compress the fourth ventricle, causing non-communicating hydrocephalus. You will tell me, guys, which ventriculi will be enlarged in this case, in the medulloblastoma, if it compresses the fourth ventricle. Third, what else? Excellent. The lateral, the third, and the aqueducts of Salvius, all of them. Okay, good. Headaches and babble edema can occur, and it can involve the cerebellar vermis, which can promote the truncal ataxia. Remember, the vermis responsible for the trunk, the hemispheres are responsible for the limbs. It can send the drop metastases inside of the spinal cord. Form of a primitive neuroectodermal tumor, BNAT. The interesting thing is this. They say Homarite rosettes, which is the blue cells surrounding central areas of neurobill. So as you can see, where it is here, yes, as you can see here, it strangely reminds me of neuroblastoma, which has something really similar to this, the Homarite rosette. Okay, so the Homarite rosette can be present so far in two tumors, the medulloblastoma and the neuroblastoma. Okay, keep that in mind. Okay, they test positive, both neuroblastoma and medulloblastoma, they both test positive for synaptophysin. Neuroblastoma, however, will be in the kidney, not in the brain. Epididymioma, most commonly found in the fourth ventricle. It comes from epididymal cells, which cover the ventricle and can promote the hydronephrosis, and it has poor prognosis. Epididymal cells origin and characteristic will be perivascular pseudorosette. So, like the Homarite rosette, but the only difference in this case, that it will be surrounding a blood vessel. So you can see the rosette here, and in the middle you can see the blood vessel. Okay, you can see the rosette here, and in the middle you can see the blood vessel. The Homarite rosette, there in the middle there was the neurobill, a tube basically. Epididymioma, rod-shaped blepharoplasts, which is basal ciliary body found near the nucleus. The next thing is a craniopharyngioma, which is like the pituitary adenoma, but it's not the same. The two main differences, the first one is the age of the patient. Craniopharyngioma is in children. Pituitary adenoma, it's more in adults. Most commonly in childhood, supratinctorial tumor, which is not typical, may be confused with the pituitary adenoma. Both will lead to bitemporal hemianopia, which is this. And it's associated with high recurrence rate, even if you remove it. It comes from Rattke's pouch. If you remember, that was the thing that it was an oral ectoderm that formed for us the adenohypophysis, which is the anterior portion of your hypophysis. Calcification can occur, as you can see here, okay? And you can see the bluish tinge of this calcification, because calcification in general in histology looks blue. So cholesterol crystal can be found, and they can have this motor oil fluid inside of them. Motor oil fluid, craniopharyngioma. How I like to think about it, since it comes from the oral ectoderm, it must have teeth in it. So calcification. Since it comes from the oral ectoderm, it must have saliva in it. So the motor oil stuff. I don't know, it's just like my idea of memorizing it. Pineal gland tumor. Which cranial nerve, before I read, which cranial nerve will be compressed in case of a pinealioma? Not 1 and 2, wrong. Remember, it must be the cranial nerve that originates posteriorly from the midbrain. Which cranial nerve comes posteriorly from the midbrain? Come on. Nope, nope, nope. Midbrain. It was cranial nerve number 3. Again, guys, 12, 11, 9. All of these comes from the medulla. 8, 7, 6, 5. They come from the bones. 4, 3. Midbrain. 1, 2. The hemisphere itself. I repeat. 12, 11, 10, and 9. Medulla. The 4 after them, which is 8, 7, 6, and 5. Bones. 3 and 4. Midbrain. 1 and 2. The brain himself. In the midbrain, third cranial nerve originate anteriorly. Fourth cranial nerve originate posteriorly. It's known as the trochlear nerve. Most common extragonadal germ cell tumor. Increased incidence in male. Present with an obstructive hydrocephalus because they compress the cerebral aqueduct that goes inside of the midbrain. They can lead to Burnout syndrome due to compression of the dorsal midbrain, which lead to an upward gaze palsy due to the destruction of the trochlear nerve that allow us to look down. And convergence retraction nystagmus, basically when you make them converge their eye, they will start shaking. And light near disassociation. Similar to testicular seminoma in histology, in which you will also see a fried egg appearance. Okay? So that's pineal gland tumors. So I guess that will be it for today. Tomorrow we'll continue. We'll finish this up. Have like 4 pages left. And we'll be done with the pathology and we'll start in the ophthalmology. Oh, not tomorrow, Monday, I'm sorry. On Monday, and we'll start on ophthalmology and hopefully finish the ophthalmology as well. So see you guys on Monday. Thank you.